Thank you, Casey. Thank you for the kind introduction. I have to admit that when Allison invited me to give a talk on suicidality and autism spectrum disorder, my initial response was, I don't really know anything about this. And the truth is, it isn't just me. It's all of us. We don't really know nearly as much about this as we should know. And I really need to credit, because I think what sparked the invitation was a piece, actually a series of pieces in Spectrum, the online periodical from the Simons Foundation, that drew attention to this. And I'll talk about what data there is, but there isn't a lot. This is an area where the big outcome, I'll just say it right at the front, is we need to know far, far more than we know right now. And so I'm here to represent that. This isn't my area of particular research, but as a child psychiatrist, I certainly have seen people struggling with suicidality and have struggled myself to figure out how to evaluate risk of suicidality in or outside of the context of self-harm in autism spectrum disorder. We need to know a lot more about this. So in addition to that disclosure, which is to say I don't necessarily know that much about this topic and not that much is known, I think it's important to note disclosures. So I have participated in clinical trials funded by the pharmaceutical industry, have also had funding from other sources. I'm not going to talk about any of that today, but it's always important to disclose. So having heard, this is the other thing, talking about a topic you know very little about in front of the director of the National Institute of Mental Health, not always your best move. Allison didn't give me pre-warning about that. So in other contexts, I've heard Dr. Gordon and others note that it isn't just in autism that we need to know more about how to impact suicidality and suicide. That we have a worrying trend in our country, and less so actually in other countries, where you see an increase in suicide over the last decades. That's concerning. We don't really have a good explanation for why that is the case. You'll note that suicide is more common in men than in women. Suicide attempts are actually more common in women, and suicide attempts are roughly 25 times more common than suicide itself. And that's good news. That sometimes means we have an opportunity to intervene because there is something that tells us that there is distress. What very minimal data we have in autism to date is that there seem to be fewer warning signs that are picked up. And in particular, you would note that this male increase in death by suicide is mediated in large part by the methods chosen in suicide attempt, or at least that's the active working hypothesis, that men are much more likely to make a single attempt and then to die by suicide, usually choosing an immediately lethal method, handguns being one of the most common, but we'll talk about some of those other methods in a bit. And that right there suggests that suicide is something we need to be concerned about in autism because of the sex ratio. In autism, and this was really alarming to see. This was a study that showed not just that suicide was more common in autism spectrum disorder, but that mortality is increased in general in autism. But this was incredibly striking to see in a Scandinavian sample that there was a 10 times increased risk of suicide in the context of an ASD diagnosis. That's something that initially generated enough cognitive dissonance that it didn't stick in our heads, and something that now going back, we have to think, why didn't we really think about this earlier? Because we talk about self-harm all the time, and we talk about aggression all the time. These things tend to go hand in hand with suicide attempts and death by suicide. But until really some of this data and some clinical data, people weren't paying a lot of attention. There was a recent study that supported this idea in a much smaller sample, in a Taiwan insurance database sample, showing that there is a dramatically increased rate of suicide attempt as well. They didn't have the power in their sample to look at death by suicide with enough confidence to confirm that. There had also been a report from a clinic that was in a psychiatry department serving people with autism spectrum disorder all of whom had IQs above the intellectual disability range, finding that the rate of suicidality, the rate of people reporting that they had had a suicide attempt or had made a plan to commit suicide, was much higher than what is generally seen in our clinics. So 35% history within the last year. And then a recent report from an epidemiologic sample that's been followed very closely over time, showing that poor social communication, what we would usually describe as, and people say this in different ways, but certainly having autism traits, but not necessarily meeting full criteria for diagnosis, was associated with an increased rate of suicide attempt longitudinally, meaning that they were assessed first for autism spectrum disorder traits, and then later observed to have had a suicide attempt. And in that study, as well as the study from the UK clinical sample, there was suggestion that the mediation was at the level of depression, and some suggestion that that might have related to bullying, although at that point, you're talking sort of levels of mediation that are a little difficult to connect directly. So clearly there's a problem. Why? Why is there a problem? And I think it's maybe easiest for us to think about some of the protective factors. So we routinely screen for suicide. It's something that's part of mental health care, should be part of mental health care universally. If you look at the protective factors that we then ask about to assess risk, almost all of them are social. And it's about connection to friends, connection to community, sometimes religious community, connection to family, and often this sense that these people would suffer if I died. And that connection may be something that's a little harder to both assess, but also harder to reinforce in the context of autism. It's unknown, but that's one potential thing. Another thing that's been identified is having coping skills and having good frustration tolerance decreases risk of suicide. This is something we know is a challenge for a lot of people with autism spectrum disorder, something that we need to know more about how to bolster. And then religion. So it turns out that one of the major factors that's protective for suicidality is religious belief, stating that suicidality is in some way unacceptable, but also providing that internal source of support. Many of the people I've worked with autism have less firm religious belief often than their families of origin. And there are various reasons we could talk about there, but that may also be a factor. There are also factors that we can imagine amplify risk. So I mentioned in the couple of studies that can even comment on it, depression is a risk factor that may mediate risk even within autism. We know almost nothing about how to assess or treat depression in the context of autism spectrum disorder. There's no randomized controlled trial. You don't even find case series. We know with a reasonable degree of confidence that depression is more common in people with autism spectrum disorder and doesn't seem to show the same gender bias, meaning in the general population, depression is much more common in women than in men. In autism spectrum disorder, it seems like it's more even. That may also, again, be about our bias and assessment, but that's the data that we have. In one of these studies, it looked as if you had intellectual disability, your risk was still increased compared to the general population. But if you had autism without intellectual disability, your risk was increased further. And that's something that is worth thinking about as we think about how to evaluate, screen, and provide treatment. The rest of this is not data from autism spectrum disorder. It's sort of conjecture based on what we know outside of autism spectrum disorder. So we know that by assessing for and treating mental illness, that we are able to impact suicidality and likelihood of death by suicide. We know, as I'll talk about in a moment, that essentially all mental illness is more common in the context of autism spectrum disorder. It's not just autism spectrum disorder. Almost any neurodevelopmental disorder brings with it an increased risk of mental illness. And then there are a number of factors that are increased in the context more acutely of suicide. So impulsivity, acute anxiety, dread, or shame, intoxication, we'll talk about that in a moment, access to lethal means. And access to lethal means is something that we might be able to push on. Self-harm and aggression are also things that we heard about earlier that are associated with an increased risk of death by suicide. Interestingly, in the very limited data we have, it doesn't necessarily look like the folks that we define as having self-harm and autism spectrum disorder are the same folks who are necessarily at risk of formally defined suicide attempt or death by suicide. And finally, I mentioned earlier bullying, which may be something that we can think about over time, is incredibly common in the population of people with autism spectrum disorder and likely associated with the depression that we see, particularly emerging in early adolescence. So where can we make an impact? And again, this takes us to conjecture land. There are actually a couple of groups not publishing on this yet, but screening for suicidality in the context of autism spectrum disorder, a group at Hopkins and a group at North Carolina, including Laura Klinger, who are using various measures. This measure, as an example, is the Columbia Suicide and Suicidality Rating Scale. We don't really know how our measures to screen for suicide, even though we use them across the mental health setting, how they actually are going to perform in people with ASD. We also don't know how to apply them in people with co-occurring ID in addition to ASD. I can say I've worked with some people who echo back the language that you're using when you're trying to screen for suicide. In fact, I had a classic example of a parent who shared with me that their child had said, "I'm a danger to myself and others," spontaneously because he had heard the question enough times. He knew that this is how you express distress. So we need to understand, and it's likely individual specific, but how you adapt our screening approaches for this population in a way that's sensitive and reasonable. Obviously, we know, and this is not just true in ASD, that we need to prevent access to lethal means. We likely need to think about changes in state, meaning somebody who is more irritable, more upset, acutely agitated, and make moves to remove potential lethal means or monitor to a higher degree. I would say psychiatric hospitalization is something that I try to avoid for people with autism spectrum disorder because it takes them out of the setting in which they are experiencing the behavioral difficulties, but sometimes it's necessary. And we do very poorly in treating people with ASD in the typical psychiatric hospital setting. With the exception of places like Dr. Siegel runs, this is something that is very hard to access, something we need to improve. And it isn't just that, we need to improve training in general. And I'll make a couple more comments. I'm now 30 seconds over time. And here I thought I didn't have enough that I could fill a TED Talk. It's very common that I'll see somebody with autism spectrum disorder and I'll think, well, why didn't somebody earlier think about the fact that they have recurrent depressive episodes? And the reason for that is often that it was blamed on their autism. So we need to monitor changes in mood state. We need to monitor for anxiety disorders. We need to monitor for things that we oftentimes neglect, things like loneliness for somebody with autism spectrum disorder who is transitioning out of a school setting where they have meaningful connections. They may not be connections that others look at and understand, but they're connections that really matter. These are things that we need to monitor and not just blame on a diagnosis of autism spectrum disorder. Autism does not account for changes in mood over time, within a day maybe, but not pervasive mood changes. And then finally, we need to treat co-occurring mental illness. So I mentioned all of these mental illnesses are more common in the context of autism spectrum disorder. The one exception would be substance use disorders, which are generally less common, although there is a subpopulation that does seem to struggle with substance use, particularly substance use that seems to be treating underlying or compensating for underlying mental illness. We urgently need more providers who will see people with autism spectrum disorder for co-occurring mental illness. We could spend a whole talk on that and why it is that people say no. They feel like they're incapable of providing appropriate care. And then we need better coordination. So in New York, in most states, you have a separation between those who serve people with neurodevelopmental disabilities and those who serve people with mental illness. We need to bring those populations together, populations of providers, so that we can appropriately serve people who have co-occurring mental illness and a neurodevelopmental disorder, which, by the way, is likely the majority of people with a neurodevelopmental disorder. Okay. And then finally, we need more research so that I could have more than one slide that talks about data. And I'll stop then.